So all five of you are young professionals, representative of a certain type of diversity of healthcare professions. Some are already working. Others are just finishing their studies. And so you are really at the crossroads, an ideal position from which you can observe the healthcare system that's coming up, emerging. And at the beginning of this journey, you still have a look and critical look about your training. This training is kind of like we could call it equipment that we put on your shoulders to prepare this journey. Is the luggage that you're carrying, is it too heavy or too light? Is it adapted or superfluous? Rethinking jobs means thinking about this luggage, and this is the theme of this edition of CHAM 2024. We're going to start with something when we think of this, and where the questions we'll be asking is the attractiveness of our professions. And I would like to ask the question. So the nursing studies are really at the podium of choices after high school degrees. They were the most solicited. Is it still the same case, or has there been a change? Yes, today the training is still attractive, but less and less. Already in 2018, we're the podium from the different assessments, and now we're second on the podium. Now we're third. So you see we're sliding down this podium. You talk about these crises to give back meaning to the profession. Yesterday it was very well said, and it's not the problem. The problem is attractiveness. We have to bring back attractiveness for our professions and our training program. Today, we are able to attract them, but we can't keep them. We can't retain them as students and even as professionals. We can't retain them. That's where we need to act. So for a profession, you have to really think about rethink the training. It has to be solid. We cannot just have a training which is not effective. And also, most of the time in the residency, you don't have this follow-up, and the conditions of interns is really difficult. So we have to think already for the training is an important point. Now, Guillaume, I want to ask you, as doctors want to do a landscape, is it for the doctors and as a president, is it the same thing? Do we have the same issues, or is the sun shining more? I would like to say that doctors are those that are happy. And now for the 2019 Order of Doctors said over 80% were happy about their jobs, and 70 would go back and redo and be medical doctors if they would be going back in the chase. So we do have the training. Of course, there are different problems concerning our social rights, parenthood issues, and as you've seen in the news, about sexual violence, sexist violence. And we have this environment. We have to continue to work in this kind of explosive environment. And one of the messages that I would like to give, because we are really modest ambassadors of the young generation, they're fine. The young generation don't work, not trying to work 20 or less. They're trying to work better, and rather than having this time issue. And so they want to catch up compared to other persons. I have one of my brothers in this another environment. He was asking the question, what is the meaning of his profession? And the doctors, like other professions in society, are also asking that question, what is the meaning of my profession? And to have a better balance between professional and private life, so that we are not a defeatist. No, we have a certain degree of optimism. Of course, we still have to work on other issues. Of course, it's not perfect. So the nurses, so you have when the studies, we don't have any statistics about that. 15 to 20% actually leave their studies, and it's less of a problem for the doctors. You, Alix, you're the head of a hospital director and Auxerre General Hospital, and they said that when you're in charge of a hospital, this is really when you've failed the ENA exam. That's what we're paying. Then you work at the hospital. So I have the impression things are changing, and things are changing well. Is that true? Well, yes, in fact, things are changing. I also will be asking these questions, but the directors of hospitals, we are really like others professionals. It's false to say that all the directors of hospitals came because they came by default. No, most of them come here because they want to be committed. They want to do something to improve the hospital situation. And so when we had the COVID-19, we saw this in the summer. We saw that management announce evolutions in the recruitment modality, putting more room for public health and also evidence, oral evidence, so also to have management capacity skills also. And we want to recruit in this kind of a hospital sphere area. And what we want to really, we want the public to know about the hospital director. At each family meal, I have to explain what is a hospital director, what is a hospital director. Nobody can tell you. What they can tell you what a nurse in a hospital or doctor at a hospital does, but not the hospital director. So we go around this table. Another question which comes up a lot, we saw this in the different debates during this CHAM meeting, which is cooperation. We represent different professions, all of us here. We work in the same place, though, in the same identity, same kind of a space. Without interprofessional cooperation, where would we be? So what, as a doctor, what I find is important, this cooperation is going quite well in the different territories, but some of them see it as a danger. I said, I would like to talk about this campaign, which was when we had the different advanced nursing practices, the liberal professions that had this crisis. Do you want to steal the steward? You want to actually steal the pilot that is steering this airplane? Now, why is there this? Why are doctors so afraid? Is it something that really has a negative impact? What does that say to our profession? Well, first of all, the problem is there is a need to have cooperation, which is not always listened to at the beginning. In other words, when we launch in our career, we have a need to create a resource that depends on others. We need to create an identity. We have the creation of one's own career path, and then you have this idea of the performance. We were talking about that initially, and this creates different attractiveness hubs. You have activities that are interesting, others that are not as interesting. And what creates initially this divergence of different needs, and the cooperation is not always there, and the cooperation is always well identified for the needs. I think more of a fear is more of actually a behavior. I don't want to be taking a corporation approach, but we're evolving this area. And what we said, the young doctors today, they have a will to collaborate more with health professionals. I give an example of cardiology, where which I represent, cardiology. We work with these advanced nurses. They have this advanced nursing practice. As a cardiologist, we have different tasks, different missions. It's hard for us to do prevention. It's a blood pressure, high blood pressure. We know this already. When you have 15, 20 million people that have this blood pressure that is too high, and you can only handle 25 of your patients. So what does that mean? What it means is that we can have all these treatments, we have all the techniques, but we need other professions to collaborate with them, so my patient can really observe their patient, the patients can actually take the treatment. And so this is why we need this new profession in cardiology that works well. In the emergency ward, it's happening also. It's starting to emerge. And also, we have the liberal professions where there's regular encounters. We have the CTPS could actually be interesting, but for the GPs, they have less possibilities of having this close collaboration with their advanced nursing practitioner. So I would like to give the example of these the advanced practice nurses but also we can also talk about the different antibiotics that are delivered in pharmacies, so that we have subjects that are coming each time where we get reactions when we have these new, we give people these new activities to take on, like in pharmacies or these advanced nurses. But but we are progressing and in this area and better collaborations area. Another element, we're saying this introduction, we're talking about when you have different crossroads now, you at your stage, and for Florence and Pauline, you're at the crossroads and a ideal position to look at for the healthcare system, to work together, to cooperate. Okay, you have to take into consideration the reality of the profession. But there's something we don't talk about enough, and this is the upstream stage. It's not just an idea of cooperation when we're training, but we see that the health faculties, which I know the best, they cultivate this difference. And even the university integration, they're part of the university, but they're not really fully integrated, these health faculties. And so you have these different doctors that become the president of the university. They're entering a new world, and they cup the umbilical cord with their first loves, their first ideal profession. And there's a separation. So because our health faculties are not completely integrated with the university, but to be working together and to cultivate this diversity, what can we say? Is it the first step to cooperate? Would that be to start working really closer together and not have this lack of integration? Yes, with the roundtable of rethinking the profession, we do have a training program which is disassociated. We have pharmacists, we have doctors, we have dentists, we have nurses, we have the physical therapists, and we see that when we regroup everyone together in the health professions, would be ideal. But we all have our own professors, our own courses, so we're not really mixing with the other health professions. Maybe we have to rethink this training, go back and have a model like we've had all the other models of different master's and doctorate program, where all of us would be at the same level. We have a core program, and then we would specialize. This would enable us. In fact, we were in the silo. We're in our professions. We have a culture, a cult of the profession. Maybe we have to go back to a culture of health. And to go back to the culture of health, we have to have a common, a core professional program. We have to have the same culture to enable us to work together. Because if we would have a common culture, we would have less problems to accept that our profession, for example, does something that in the present which is attributed to us, and we could work together. I'm a pharmacist initially, and in the pharmacy we talk about attractiveness. And it's suffering, though, because there's not visibility, because, in fact, the pharmacists are everywhere. They're in aeronautics, they're in agriculture, they're also with the cancer experts, they're in the labs, they're also in the pharmacies. Pharmacists, we are very diverse. We all have this common culture, this core culture from our faculty training program. So we've accepted that we all have different jobs, but we also have this link. We can go from the hospital to the industry easily. We can go from one area to another because we have this core common culture. And so I think this is really to get away from the professional cult. We need to have more flexibility. If we had this common core culture for the healthcare, that would be better. And so we really have to, then the role of universities, I believe, is to give us this core culture, and rather than just this specialization and silo effect. Why is it not quicker? We've been already waiting yesterday. We've heard the young people, we want them to launch different missiles. I'm trying to ask this question. It seems obvious what you're saying. Why are we lagging behind, Florence? Why are things not going behind or going quicker? Because there's this, we have this model that is safeguarded. Big health is really looked at as something really disassociated, and we can't look at it as a profession like others. Each time when we launch a reform, we have to have the different different educational program that has to be formed very slowly. The ministries are actually changing very quickly, but that does not facilitate the situation. But we have to change mentality. There's different new professions that are entering. We want to work together, but it's important that we can do this, and this takes time. It's going too slowly, and so I think the young people, they want this. They really want to be working together, and I think the fact of talking interprofessional when we work, when we do this at a later stage, it's too late. We need to do it upstream. It's too late to ask people that have 10 years of study saying, now we're going to what you've learned to do, and now we're going to give it to someone else. We're going to transfer your jobs to someone else. Now, we were trained for a specific job. It's not possible to say after 10 years, we're going to take away this skill. No, it cannot be seen as something we take away, but something that we share. And then we do this early on. So as a nurse, do you share this observation? Yes, I agree with Florence. It's really the problem with our training. In 2024, we can't have these disconnected silo training. We have core modules, but because we don't realize that other professionals also have different shared skills because we're in a silo. So I think we need to, our identity is really important. And it's important to have this interprofessional culture so that we can work together and not come when we're professionals just to really lay out all the different professionals. And at that point, when we start working to do this, no, it's too late. We need to think of the construction of the healthcare system. We need to have a holistic approach for the healthcare for patients, and the patients have to be at the center of reflection. And when you talk about the different, as the head of the universities, how do you transmit this message? Everyone, how do you do this? It's very complicated for us. We have 340 different establishments throughout the territory, and they're far away from the universities. Take the example of the health program. This project should have interprofessionalism amongst the different students, but it's not very well set up. And so it's too complicated to really adapt the different schedules of students. And so so we're not working with the other professions as we could have because of the schedules. Now for doctors, the same. We have 1 month of internship in the hospitals, and also where we are to discover the job of nurses, for example, and then we're young doctors and we want to see the surgery. So we do 1 month at the beginning of the program, and then never again do we do this interprofessionalism. And so we were talking about this program, EDHS, which is the directors of the hospitals. We organize a weekend every year where during one weekend we're thinking together with the directors and the different participants. We think of the future of the hospitals. We have different themes, and we realize, and we start, in fact, I think this was already the case where you had this game where we put all the different on the board, we put the prejudices. And one word that comes up all the time is the different failures from the ENA program. They say that people are directors because they failed the ENA exam. This shows that we have lots of prejudice when we enter this weekend with these people that we don't know. And then at the end, we see there's been a progress. We want to redo the world after this weekend. There was a tribune that was done with the doctors and the directors of hospitals that really spoke a lot in what was they had good points and bad points, and there were some different good approaches. So there is hope. So we want to talk about the technical aspect and technology. So we've discussed this a lot. We're talking about artificial intelligence and new technologies. We're not going to go over this too much, but it's really the beginning and the beginning of the use, the common use that is more generalized. There is a subject. I would like to go back over this theme, which was also part of a roundtable. And I want to ask the question to Isaac to say, now, the healthcares today, do they use, we know they use these new technologies, artificial intelligence, they use it for image reading, for example, retranscription and synthesis of information for the different reports. Now, so this new generation are health professionals in Pacific. That's everyone, and I mean the directors all the way to the different people who work on the area of health. So is the idea to let these health professionals to have these caregiver engineers, or just engineers, or we have health professionals and engineers, or will we have caregiver engineers that arrive? Isaac. I don't know if I'm in best position to answer this, but together we do have a role as health professionals to distribute what we have in common. We have spoken a lot about this. Each one of us will have really a different part of this resource. We'll be handling prescriptives, deliverer, for the different prescriptions, the different, also we do the different acts, but also we are part of ourselves in a system where we have attractiveness hubs that reinforce the use of technology. So these are for the primary acts that can be allocated using technology. We can see this. Today, we can have certain access to the carticel we use for prescriptions. So this is something that can be delivered in the pharmacies. Now, how can we rethink together all of our roles for this common need that we have? This is the question we will need to raise. And how can we break down these different tasks? There is not just talking about a profession. If we are together, all part of this common good as citizens, and one part of the answer say, above all, we are all citizens which distribute this health good. Guillaume, you spoke a lot about this. You use this new technology. How do you see the answer to this question? Do you see, are we going to have a caregiver engineer? Or will it be hybrid? Will it be hybrid, or will it be separated? So, for example, you can have access between. We've had a lot of engineers that became doctors, so things are changing. The culture is changing. Do you think it's something that will become normal to have this caregiver engineers, or do you think it's a different professional? There's no need to have a hybrid approach. The first element is in our training. Artificial intelligence is something which is like a wave that's come upon us, and we have to be prepared. We have to have the right surfboard, otherwise we'll be submerged. And this is to be integrated in the training program. There's a concrete example as a cardiologist. When I was in intensive care at a small Parisian hospital in the 13th district, and we do have complicated patients, and we try and ask ChatGPT for a diagnosis, but to be honest, we didn't really have many expectations, really for more fun. ChatGPT gave us an article from this special medical journal, which is one of the top journals, and it was the author and a year which didn't exist. ChatGPT just invented an article which was written, and this is really a worry. So you have the different versions of ChatGPT. They've evolved, of course. We brought that to our attention this weekend, in the different weekends. If I don't know how to handle this ChatGPT, then I can make big errors. So you have this training. Is it present to have this kind of training? No, we we use this new technology without real training. And I also think you have to have there's a fear of some doctors saying that artificial intelligence will replace the medical professionals. And I put some brakes on that. I would simulate artificial intelligence as a super tool, and you can have the best stethoscope. If you don't put it in the right place, you can't listen to the heart. So there's a tool. So also to really put default in artificial intelligence, to have a critical spirit is important. You have to master. You have to be trained to, and this is very important. The second part of your question is if you have a doctor engineer, we research we should mention is becoming more technical, and we scientists are becoming overwhelmed. First, we did the fundamental research, which was basic, but actually there were some very, very good clinical trials. But now we see that there's this deep learning, and the artificial intelligence does research using these algorithms in a new way. So there's these new jobs coming up, engineers, data specialists using this technology. So the question I want to ask you, we're talking about technicity, high technology, and for me, there is the contradiction here. We're talking about these we have a healthcare system which has two things. First of all, it favors extremely innovative, costly therapies and very promising, which are economic and sovereign. And on the other hand, as we have the French want to be well treated in an optimal fashion everywhere and to have an appointment. There's a discrepancy and a gap here. We cannot choose between both. We have to be able to assume both those missions. Most of the professionals in the health sphere are trained at teaching university schools, and they made a choice. I'm taking the professors, and their DNA is connected to innovation. And their choice to say, yes, we have to go in depth on this innovative therapy. We have to have the technicity. You're a cognitive urologist, you're a neurologist, so you're a cognitive neurologist, for example. So we have these different multiple skills. You have to handle these both jobs. Now, the question is, now the abundance, is it dispersing? Is this technicity having a negative impact, so it's hard for us to really follow our major essential mission? And Florence, what I want to ask you, because in your capacity now, is the teaching university hospital is to train these different medical staff that can train in a general fashion. Is it the teaching university, CHU, is it the best place? Or what is its place? And what could be this new place? Where would be the best place to do it? It's not the same area. Now, we talk about neurologists, and I say very rarely in my area. So we can specialize in many different areas. I also work in the small hospital, the 3rd district, and we have complicated patients. I have young people that will do the biomedical area, and they come to do their 6 months of residence, and I help them. People that have thrombosis, they are bleeding. We do things that are passionate and extremely interesting. My profession represents 1 to 2% of the biomedical area in France. Behind it, these young people that are in residence, I show them the different aspects of the profession. 70% will be in the different labs, and they will be have multiple tests, and they will be doing these tests which are basically normal, but it's complicated to tell them. You see this exercise here, which is fantastic. You see, you're at the beginning of your studies, but you will never do this in practice. So how can we give them desire to do the multiplicity of skills? And I say, I don't know this job because I don't do it for this exercise, and it's an issue. because I was the head of clinic just for a few months now, and I just come out of residency. How do I train those in residency? We need to have these specialists, hyper specialists, but if we can be super specialists, it's because we have people that are behind this also have multiple skills. They can help us really identify these complicated cases and have a solution. So we have to send these in residency at the beginning and the different exercises in the cities where they're going to be actually working. And then they could come back to the teaching hospital. Once they have the basis of things, I'm teaching them things when they don't even have the base of their profession. So what do we do with someone who's bleeding? Maybe you have to have certain skills for interpreting correctly. This is the problem of these teaching university hospitals. They have the monopoly. So we have to have those in residence because we need them, but we don't train them. We don't give them desire to do their profession. And this is what those in residency say. I don't want to go into the private sector. That doesn't attract me. I understand it doesn't attract because we in the teaching university, we don't put high value on these multiple skills that we think those who want to do so think they will be going in. It will be a failure. So what we need to do at the university hospitals, what is the image that we give of the other professions for those who are not the super specialists, and how can we preserve this teaching university training program in a good way, and also to ensure this multiple skills, because it's important. You have to have a blood test analyses and these other kinds of tests. Now, so the role of the university, what is it? Is it to create and train and give education, or is it to help someone learn a job? Yes, it's to really gather knowledge. Yes, but also to have a certain skills and professional skills also is enough for the teaching university hospitals. It also has an important role, but today the issue is we learn our profession thanks to these teaching universities, and maybe that's an issue. Now, there's a lot more technology. So, like, for example, the director of a hospital, Alix, you think it's the reverse. It's more important to have multiple skills. Yes, it's at the heart of our skills, the heart of our jobs. We have different establishments, different territories where we work, and to really exercise our profession, we have to have this 365-degree vision. We have to coordinate projects. We have to make contacts between different professionals. We have to have this multiple skills. I find this multiplicity of skills is something, and transversal skills, you find this at other professionals of the hospital, because with the reform of the governance and the delegation of management in the hospitals and the different heads of the different departments, they have to do management, they have to do project management. So once again, we have this polyvalency, multiplicity. So we we have to also be specialized in certain technical management areas, but also the medical areas. You cannot, as the head of a department or the ward, to train, but if we also, the directors of hospitals, we also have to have that training. We have this in the initial training program. We do have this program, but it's not enough. So you think there's a regulatory aspect because politics is important. Now I'm wondering, in one word, for you, does politics have a role to play, or should it be done, as we call it, within the group or the family? What we were saying earlier is we have a lot of things that are done, as we call the family, for the different directors, but we would need to have the institutions should help us. We hope things are going to emerge in that area. Just because we're going to be concluding, we have 4 minutes left concerning politics. So we were talking about this period of frugality for the different budget issues. So that's the current trend. Is that something that is possible to do better with less resources? It's not easy to do that with the aging population, with these chronic illnesses. I would like to ask Isaac, how, in your opinion, we've spoke about this, how should the young professionals rethink their professions to think about this? So how can we have frugality? So this is what do we need? That is this a big subject? Frugality and good control of expenditure. Yes, you use the good term frugality. It can be an aim in itself. We should favor innovation. Innovation goes through technology. We spoke a lot about that. If we rethink of our organization, that we can learn to do that. Our organizations is something that learns, as I'm saying. So, and what is the goal of doing all that? When we have this principle, we have this hyper-technical hubs, and the dissonance is leading to this different crisis in the health area. We had the COVID. We always want to have this economic savings in our different cost in the health area. So the idea of what do we do, what should we be, is to have a vision. We have a strategy to defend, which is health care, because the existence of hospitals depends on the capacity available. In the area of defense, where I evolved, we do see that resilience is important, and healthcare is gives dissuasion against different externalities. And this is the meaning of our commitment. The responsibility that gives us is there, and we can recreate ties. We together are all defending health as a common good. And we are also tenants, as I like to put it. And if we think about this idea, we could have a new form of commitment we can create, which goes beyond this. We can have this initially, the humanist commitment, but now we're seeing that this is deriving to get the good plan for the healthcare system. And so we're always looking for the good plan. This is what our studies, our education teaches. Now we have to rethink the essentials, fundamentals. We're here to protect our citizens. That's our mission. And if we think of this notion, we will be able to commit ourselves and be committed together for this. Yes. A word of conclusion. I'll be very quick. 3 words. First of all, we are in an era which is really very, very different. We've gained 15, 20 years of life expectancy in 20, 30 years period. So people that live 15 years more, they cannot always follow the rhythm. So when people live 15 years more with such intensity, so we're Homo sapiens between some X amount of million years. So this is something exceptional what we're living. So things, when you take the different challenges and expectations, they're not the same. The paradigms are evolving. We talk about the Carticel. The Carticel is because it reveals a new form of thinking. Today, a new discipline has emerged, which is cardio-oncology. Cancer itself, you're not just there to say, how can you treat cancer, but also to really be interested in the chemotherapy on the heart. So you have the breast cancer treatment has really evolved. And because it's not just related to cancer, I don't know if that will support epidemiology, course, says the moderator. But another positive factor, when you take the history of France, we had different 2 empires, 2 monarchies. We had all these different transformations. France, Michel Nivoque, a historian of the Republic, who said France doesn't like stability, but France has always solutions. Thank you for this word of conclusion.